Welcome to another episode of Key Into Quality, a Mayo Clinic podcast focusing on healthcare quality and experience trends and solutions. I'm Dr. Tim Morgenthaler, a professor of medicine at the Mayo Clinic and vice chair of Mayo Clinic Quality. Today, we're going to talk about improving early sepsis recognition and response and how innovative approaches, including AI-supported alerts and multidisciplinary collaboration, are helping clinicians meet SEP1 requirements and improve care. Co-hosting today's conversation is Sherry Nemec. Sherry?
Welcome, everyone. I'm Sherry Nemec, Consultation Relationship Manager for Quality at Mayo Clinic. Early sepsis detection and response has been a challenge for so long. And despite advances in care, it continues to be a challenge for clinicians.
The thing is, I know when I gave that introduction, I used words like SEP1, which kind of might begin to turn people's brains off. The reality is every hour of delay in treating sepsis increases mortality. What if your team could see the clock, understand the gaps, and act in real time? Studies consistently show that every single hour of delay in antibiotic administration increases the odds of death by about 7% in many studies. And so I kind of did a little back of the napkin math. There's about 1.7 million cases of sepsis treated annually in the United States. So that 7% per hour translates into 18,700 potentially preventable deaths per year, assuming everything went well. So the question is, why doesn't that happen? It sounds so simple. And I think today on Key Into Quality, we're going to explore how Mayo Clinic Florida tackled this challenge. You're going to learn about how complicated it actually is, and that they pulled out many different tools, including AI-supported alerts, real-time checks, multidisciplinary teamwork, modifications to the EHR, a lot of different tricks to make this all work better. So whether you're at the bedside or behind the data, I think this episode is going to challenge about how you think with regard to improving one of healthcare's most time-sensitive conditions, and that's sepsis. So our guests today are Dr. Devang Sanghavi and Dr. Kristine Thompson. Welcome, both of you. Thank you so much for joining us.
Thank you for having us.
Thank you for having us.
Dr. Sanghavi, could you just tell us a little bit about yourself? Where do you work? How did you get there? And how did you get involved in this project?
I'm Devang Sanghavi. I'm intensivist here at Mayo, Florida. Many years back, I trained in Mayo Rochester, did my fellowship there. Prior to that, I trained in Chicago, did my residency there. I started working here in Mayo, Florida, I think just before COVID in 2019. And I currently serve as patient safety officer in Mayo, Florida. And sepsis, being an intensivist, is a passion of mine given the number of patients who have this condition. So that obviously and naturally attracted me to this disease state and how do we as a group organize better to treat our patients was a research area, a passion of mine, and has been since I became an intensivist.
Thank you. So, Dr. Thompson, would you do the same for us, please?
I'm Kristine Thompson. I'm an emergency medicine physician in Florida. I'm a Mayo lifer. I did my residency at Mayo and came directly to Florida to start my career. And I arrived at a time when all of the CMS publicly reported measures were just getting off the ground. So I'm aging myself a little bit. But when I first arrived, I was offered the position of a performance improvement officer for the hospital for these publicly reported measures. So, of course, we started working with pneumonia back then. And as more and more measures were added, more and more work fell into our bucket of things to work on. So that's how I got involved. Right now, my current position, I am the chair of the Mayo Clinic Quality EHR Optimization Subcommittee. And our job there is to try to find ways to optimize the EHR to meet publicly reported measures and improve safety and outcomes for our patients.
Dr. Thompson, I think you and I have been working together in various roles, probably let's just say for at least 10 years. And I know that your interest in using the EHR to help drive improvement in patient care is not new to you. What was one of the first projects that you worked on, out of curiosity? I'm trying to remember way back. It was when we were using GE Synchrony.
You and I worked on VTE for many years. So that was a big one that I worked on. I worked on surgical site infections. I worked on any of the new, hot items that were coming out of CMS fell into my lap. And so whenever these new measures are published, our small team would go through and figure out what the new specifications look like, how it impacted our performance, what our performance was going to be, and then how we could potentially change documentation or coding sometimes, things in the EHR that would improve our performance without interfering with the great clinical care that we knew that was happening. Oftentimes these measures, as you know, your pass or fail rate is based on your documentation, not your clinical care. And so a lot of the work that I do is trying to figure out how we can improve that documentation to match the great clinical care we're providing.
So tell us why you first got interested in this particular problem and how you started to, design your approach. How'd you get started?
At Mayo, Florida, we had a committee that was called the Clinical Practice Quality Oversight Committee. And that committee was very interested, of course, in our measure performance. And when SEP 1 first came out, measure performance was not great. And so they spun off a subcommittee from that was a quality sepsis work group in Florida. And it was a multidisciplinary work group. I was the emergency medicine representative for that, but then also worked on the EHR side of it in that role that I had. So that's how I first became involved in working in SEP 1 was through that subcommittee. And when Dr. Sanghavi arrived in Florida, he was quickly tapped to join that committee as well.
So just a little follow-up on that, Dr. Sanghavi. Dr. Thompson expressed that, a lot of the work in the EHR is to aid us clinicians in making sure we document what we're doing, and it's especially helpful for doing good things. You're the clinician in the ICU. What was your assessment of the care that we were actually providing for sepsis? Do you think we were hitting the mark all the time or not as good as we should? Or what was your thoughts about that?
One of the biggest challenges when I first arrived here, Epic is an amazing EMR, but we all agree that there are gaps, especially when a patient transitions from one unit or one level of care to another. There is a gap. We clinicians do a good job in handoff, but there are multiple components to it. The care doesn't stop, care continues. However, the gap, especially in sepsis care, is because of the time sensitive nature of sepsis you mentioned in the introduction. Each hour delay leads to 7% mortality, increase in mortality. So imagine a patient coming through ED, going to a floor inpatient unit or general ward, and then coming to ICU. That itself can take hours. However, the sepsis care doesn't stop. And that we realized was a gap in our EHR is to how do we make our clinicians, our providers, our nurses be aware that the clock is ticking, literally, and we need to complete the components of sepsis care in that time sensitive manner to help our patients to improve our outcomes and to meet our SEP 1 compliance. So that was a big challenge that we noted. We were aware of it all along, and we were trying to see how do we organize a team to target some of these gaps that we have observed or noted.
So, Dr. Sanghavi, let's jump right into that and talking about the team. Who did you start to involve in this work?
As Dr. Thompson mentioned, we had our sepsis quality work group already. That group comprised of clinicians, nurses, pharmacists, our EHR experts. So we had the skeleton of the initial work group that sepsis had provided us the launchpad or the framework to jump onto this project. So a lot of the team members who were present there were part of our team who led this project and kind of worked together. But as we started going along, we needed more help, more resources. So obviously we went to our enterprise work group, enterprise colleagues to get us specific helps in terms of modifications to the EHR. We had a need in terms of components for manually validating the alerts that were coming through. So we asked our Rochester colleagues who had the EICU whether they could help us in terms of validating those alerts. So this was a really big team at the end with a lot of components, and it really worked out well given the multidisciplinary nature and wide participation of various team members across the enterprise.
Dr. Thompson, anything you want to add to that?
Yeah, I would just add that initial work group, what they were doing was basically evaluating fallout. So we were looking at cases that didn't meet the measure and trying to figure out why it happened. Was there something that we could change to prevent it from happening in the future? So we spent many years looking at our failures, admiring our failures, and really struggling to make changes that were big enough to move the dial in this area. There was a study that came out of Rochester while we were working on this that showed really great outcomes from sepsis. And so it was very difficult to convince the frontline team members that they needed to do something different in sepsis because our studies were showing their outcomes were great. So then it became, do we want to spend resources to check the box for the SEP1 measure when actually our outcomes are fabulous?
I want to put a little break there because I think this is a really important point. I believe has possibly played out over many hospitals. So great sepsis outcomes in studies that were kind of looking at what happened when somebody came to our hospital and they were septic, how did they do, really makes you say, well, I never want to get septic, but if I do, I want to get septic here. But not outstanding performance on the SEP1 measure. Spend just a few minutes, either or both of you, talking about that controversy in our nation. How does that happen?
Yeah, I can speak to that because I've spent many, many hours trying to convince my colleagues that this is a measure that's worth chasing. So for many years after that study came out, when we would try to approach clinicians about this, they would say, I'm not going to change what I'm doing. Our outcomes are great. That measure is dangerous. I think a lot of people that are listening will remember that when the SEP1 measure came out, there were a couple of components of it that really good clinicians thought were inappropriate care. So there was the requirement that you had to use a broad spectrum antibiotic. So even if you knew the organism from a blood culture yesterday, you were directed to use a very broad spectrum antibiotic, which at the time we felt was not great care because we were trying to be cautious about antibiotic resistance. So we hit that wall. And then the next one was the fluids, which became just anti-SEP1 call across the country in that there were no exclusions available for giving that 30 milliliters per kilogram fluid bolus for anyone who had even mild hypotension. And we knew as clinicians that if we gave that amount of fluid in that time frame to vulnerable patients, we would hurt people. So many clinicians at our organization threw their flag in the ground on that one and said, this measure is trash. I'm not going to do it because I'm going to hurt people. I'm going to continue to care for people the way that I know to take care of people. That's been a huge barrier. And that belief has persisted for many years, even after CMS updated the measure to be more reasonable and allow for exclusions and allow for any IV antibiotic. It didn't have to be a specific list. The belief that that measure is trash has permeated through the entire organization and I think through the country. So it's made it very difficult to get buy-in and belief in working on this measure to get the performance where we want it to be.
Well, and so you've mentioned one of the big challenges, which certainly has been a big challenge. Do either of you want to speak to other big challenges and interdependencies as you started to organize our teams to not only continue to have great clinical outcomes, but to start to do better on the SEP1 measures?
One of the biggest ones, I think, for emergency clinicians is that oftentimes the alerts come after you already know that your patient is septic. So there's this whole issue that we deal with timing the alert correctly and giving the appropriate information to the clinician that they need at the right time. Most of the alerts that you can build having to do with SEP1 are based on abnormal vital signs, fever, abnormal lab values, all the things that the ED clinician is already constantly assessing as they're working on the care of their patient. So when you're popping up an alert to them, telling them something they already know, they immediately dismiss it. So one of the big challenges was trying to figure out how to give them information that they could actually use in the right time frame. That was different for the floors. So when we started working on how do we improve performance on the floors, they do have more of an issue with early recognition. We do need to notify clinicians that their patients are potentially becoming septic because they're not at the bedside continuously assessing every vital sign in every lab that comes back in. So our approach to how to solve these problems was different for the ED population versus the inpatient population.
The other big challenge, especially I work in the inpatient setting, is I have my patients that I need to take care of. And if I start getting alerts, which may be false positive, it hampers my workflow given the acuity of the patients that I'm dealing with. So we were very mindful from the onset that we don't want to send the alerts to our frontline providers from the get-go. Given that this was an AI tool, we wanted it to be sensitive because we didn't want to miss any patients who were potentially septic. And we knew that there would be some false positives. So we wanted a human interface, a clinician who could look at the alerts, vet whether the patient is truly septic or not. And if they thought that the patient was septic, then pass it on to the bedside clinician saying, hey, we feel that this patient is septic. Now you go look at the patient and do what you need to do based on your clinical acumen. So that was the cornerstone of our approach in terms of how do we protect our frontline clinicians from overuse of alerts, but also the autonomy of the frontline providers in deciding and managing their patients was paramount. We didn't want some third physician who was not even at the bedside to decide and treat their patients. So those two principles were guiding principles for us when we started and implemented this tool.
I'm going to make a statement and I want you to push back on it or agree partially with it or just tell me it's complete garbage. But you guys outline it actually very nice in a paper that we will make sure there's a link to your paper, which was titled Improved SEP1 Compliance Using AI-Supported Tools. And it was published in ICU Management and Practice 2025. It's my impression after reviewing that and listening to you and some of the work that I've done at Mayo over the years, there's a perceived need for electronic tools, particularly maybe smarter electronic tools, to help with early recognition, particularly depending on what setting you're in. But what we've learned over and over again is that those electronic tools, if you tune them so they're sensitive enough, they have too many false positives. And if you wait until they have a very high false positive rate, they're not as sensitive as we need them. So for right now, we need a combo system that has some kind of a sepsis sniffer and then a human interface to really do a bit more digging and validation before they then involve the team that's taking care of the patient. Is that where you think we are right now?
Absolutely. I think you got it right. We want by design the tool, the sniffer, to be sensitive because we don't want to miss even a single patient who is potentially septic to not be identified by the sniffer. But we also don't want our frontline staff to be inundated by excessive alerts. So that need for human interface for validation is crucial, not just for this sepsis tool, but for any AI or sniffer tools that are created in future. We don't want our frontline staff to kind of start like validating whether this patient has a shock or sepsis or PE. That has to be done in an independent fashion. That way, the day-to-day workflow, be it a hospitalist or an intensivist or an ED clinician, is not hampered because those patients that we take care of, they also need care in a time-sensitive manner. That's why like validation independent of the frontline providers is crucial according to me.
Now you've described a decade of learning or more, and I suppose that brings us to another challenge that I'm sure you guys faced, which is, okay, you're coming to the conclusion that you need a team next to the team to help manage this process. Now we're talking resources, we're talking expertise. So who did you bring into the party and how did you get that done?
Absolutely. I mean, given that we are Mayo Clinic and we are one Mayo with resources across the enterprise, we and Mayo Rochester have a EICU. EICU team manages patients who are not on Mayo Rochester campus, but they're elsewhere, be it Mayo Clinic Health System, or they actually helped us during COVID monitoring and taking care of our COVID patients in Mayo, Florida. So we had an existing relationship. They had the bandwidth to support us. And that's where we leveraged our enterprise resources. We reached out to them and said, like, hey, we have this sniffer which would bring up alerts. We want your experienced nurses and providers to help us validate it. We just want you to see that if this alert that comes up, is it truly a septic patient or is it just like, a noise among the signal? We worked with them, created a workflow which was acceptable to our bedside clinicians because the question of autonomy, question that my patient should be taken care of by me, myself, that was paramount. We didn't want somebody else to take care of our patients at the bedside. So we created a workflow wherein they were just validating, passing it on once validation, the actual care of our patients to the bedside clinicians. So engaging our enterprise colleagues, the EICU team, to participate in that validation and then passing it on to the clinician at the bedside, that workflow creation took us some time. And we went through different provider groups so that they were agreeable for us to do this workflow in the fashion that we created. Once we got the buy-in, then it was simple. We turned it on. We used the tool in a pilot phase to see what kind of data was flowing. And then we started implementing it. And to our surprise, there was a great buy-in. It's still going on well. And our clinician teams actually love it. the very concept of protecting our frontline clinicians from getting excess alert is actually the secret sauce of this project being successful. They feel that somebody is watching, getting the alerts and passing it on and letting them decide whether the patient is truly septic or not, and then taking care of the patient in the manner that they would like to take care of.
I just want to touch on that a little bit because Dr. Thompson mentioned how difficult this was earlier about getting buy-in. Can you talk a little bit about how did you do that? How did you get people to buy into this?
So, in order to get people to buy into this, we had to spend a lot of time myth busting, is the way I would describe it. So, we had to do a lot of education about the new measure, that the SEP1 measure, while it's been around a long time now, had improvements made to it that made it more reasonable. And we had to explain to the clinicians how the new changes to the measure made it actually a good measure of how well you're taking care of your patient. As long as you could put in your reason for not giving your 30 milliliters per kilogram of fluids, and you could choose any antibiotic that you wanted as long as you gave it IV. Once clinicians heard that, then they were more accepting of the measure. It was getting rid of a lot of that bias around the measure that existed from the previous iterations of that particular measure that I think was really helpful in getting the buy-in. The second thing that really helped us, that actually happened after we were working on this project, was the inclusion of step one in value-based purchasing. All of a sudden that got some very high level attention, which was passed down to the frontline teams as well. So we had started working on this before step one was added to the value-based purchasing portfolio, but that gave us an extra boost, an extra injection of energy into a desire to meet the measure.
I think in the article you talked a little bit about champions. Would one of you address just a little bit about the champions for that buy-in piece?
Sure. So as we were trying to decide how to roll this out, we needed champions from each of the areas that were going to be impacted. So we had nursing champions, we had physician champions from the ICU, from the ED, from the inpatient, mostly internal medicine teams, working to try to eliminate that bias and to give direct feedback to their colleagues. Because I think when you hear feedback, especially negative feedback or something about a performance challenge, it's better received coming from someone who is doing the same job that you're doing. We energized those champions. We empowered them with knowledge about how to pass this measure and about a lot of the barriers that we were encountering. And then we asked them to go to their colleagues and spread that knowledge and try to get rid of the negative perceptions around the SEP1 measure.
So you guys have done an amazing amount of work, an amazing amount of influence, and really great technical work. It's really amazing to see what you've done. What are the worries or concerns that are kind of keeping you up at night about this project now?
Let us take a few steps back first. So why did we do this project? As we said at the onset, that there was a lot of variability from month to month in terms of our performance. Some month we were actually doing 85, 90% SEP1 compliance. We were doing great. But some months we were doing, say, 50, 60% in terms of performance for our SEP1 score. That was the biggest challenge back then. With the rollout of our STEP tool, our variability, the fluctuations that we see month on month, has actually decreased. The biggest concern that I personally have is we are relatively just at the beginning phase of the project launch. So we launched this in March of last year, just a little more than a month, a year and a few months have passed. My concern would be that we may lose momentum at some point in time, given that, as time passes, people get not as much alert or in tune with this alert, with this tool that we have launched. So taking care of septic patient is a daily affair as an intensive, as a hospital, as an ED clinician. And I think the work of this work group, the sepsis quality work group, is, although we have great performance right now, I think we need to have ongoing kind of outreach to our stakeholders who take care of septic patients on a regular basis so that we just don't lose the momentum. That, I would say, is the biggest challenge with any project with quality improvement, is that you see that great result when you're doing the quality improvement project, but then there may be a dip, and we don't want that dip for the sake of our patients, for the metrics that we care for this project.
So things that keep me up at night are the turmoil that's going on within CMS and all of the changes that are being made to these measures, because each time a change is made, it presents a new set of challenges for us in trying to meet those measures.
So where do you go from here? Besides trying to keep this going and consistency and all those pieces, is there a next step for the project team?
We have launched this in Florida. It's working well, as you can see from the numbers and the performance. We mentioned that we are one Mayo, right? We have the advantage of having enterprise approach to how we do things at Mayo Clinic. So this tool is available for our enterprise colleagues to use. We are in talks with our enterprise partners in Rochester and Arizona and health systems to see whether they would like to use that. And some have expressed interest in terms of doing this. We actually have started through Kern Center, E-STEP, which is Enterprise Sepsis Improvement Project for enterprise colleagues. So we'll see how the buy-in from our enterprise colleagues is, and if they want to implement it there, we can certainly share what we have learned in the process of rolling it out in Florida, and we are available to help.
Also, we are constantly iterating on our tools. So one thing that we haven't talked about is one of the big goals that we had for this project is to get information on whether or not someone was passing the measure at the time that they were caring for the patient. Traditionally, we, as I mentioned earlier, would have a mini meeting where we would look at the fallouts, and then, a month or two after the patient was discharged from the hospital, we would be feeding back to the team where their opportunities for improvement were. What we wanted to do is to get that information to that frontline team while they were still caring for the patient and had the opportunity to intervene or change their documentation or improve their documentation while they were still taking care of that patient. So we developed this electronic checklist that is rolled out across the enterprise. And so as people see and interact with the checklist, we're constantly iterating on making the checklist more accurate or more reflective of whether or not you're passing each component of the measure. The checklist that we created is dynamic and it's patient specific. And so it's taking people a little bit of time to appreciate that when they first see the checklist, it doesn't have all the components on it because their patient may not require fluids at that point. Maybe they weren't hypotensive or they didn't need to have vasopressors. So we don't show them banners asking them to do those things unless their patient needs it based on documentation that's in the chart. So we're constantly updating and iterating on that checklist and making sure it's more accurate. The other thing we're working on is trying to improve the accuracy of our alerts to our frontline teams. So in the ED, that's a best practice advisory or hard practice advisory, as they're called now. We're fine-tuning that alert to try to incorporate more of the end organ dysfunction so that when someone sees a sepsis alert, it's giving them more information than it does currently. And we're using that alert to start the checklist and timer, which is really what we're trying to get to. Is we're trying to identify these patients early and get the frontline team to start that timer and checklist so that while they're caring for the patient, they can be checking it and making sure that all of their documentation and care is being delivered in the way that it needs to be done in order to perform well on the measure. It's the same on the inpatient side. We're continuously evaluating the AI tool, the model performance, the interaction with the EICU to make sure that we're doing everything we can to make the system perform well from end to end, from the ED all the way through hospital discharge for these patients.
Wow. So we're getting close to the end of our podcast, but before we end our discussion, I just have to ask, Mayo Clinic's been working on this very systematically with a lot of research and publications for a long time. What would you say to an organization who's just starting to roll up their sleeves and say, okay, really, we are going to get serious about our sepsis care and our SEP1 things? What would be like your top 2 or 3 words of advice for how should they get started?
The secret sauce for any organization to solve this very difficult puzzle is the very foundation of it, which is the multidisciplinary team. We had the team already before we launched this project, and that team represented the whole gamut of inpatient practice from ED to ICU to our hospital floor, providers, nurses, pharmacy, our IT support. I think that is crucial. It doesn't matter whether you use this AI tool or this EMR, that comes secondary. I think the foundation of any solution to solve a problem like sepsis is to have a very strong multidisciplinary team. I would say to start with a great team first and then figure out the solution, the EMR part later.
And that makes sense because it's a very complex disease and treatment process that usually spans more than one location in the hospital and involves a lot of different people. So that makes a lot of sense. What would number 2 be?
For me, it would be making sure that anything that you do to alert providers or give them documentation tips is coming to them in real time while they're still caring for the patient. Be really cautious about making sure that you're not over alerting, and that if you are setting up interruptive alerts, that they're giving clinicians information that they need or can use in real time while they're caring for the patient.
I know that's a lot of work. Do you have any other tips before we close out here?
And don't give up. It's frustrating because we've been working on this same measure for so many years, and we've been hearing about sepsis for so many years. There's been so many publications out there with all kinds of different ways to approach this. But as you opened with, it's so important. And every time that we go to a group or talk to people that include patients or staff members, we always hear stories about people who have lost their loved ones due to sepsis. And so even though it's frustrating and it feels like we've been working on it forever and not making any progress, it's a really important clinical scenario that needs to be given the attention that it's getting because it is so impactful.
Yeah, ultimately, it comes down to the impact of our patients and the families that we're serving, bottom line.
Well, I just want to say thank you to our guests for sharing not only the details of your work, but also your heart behind it, because that's so motivating to all the rest of us. Sepsis does remain one of the most urgent and complex challenges, I think, that we face in healthcare. And today we've heard about some practical innovation, real-time tools, and how committed teamwork and actually making the team bigger can really make a measurable difference. It's so complex, but I think together we can make a difference. So to those listening, whether you're in quality, frontline care, or leadership, I just want to encourage you to reflect on what you've heard and consider how similar approaches might improve care in your setting. When we work together to close gaps, align teams, make bigger teams, act quickly, we don't just improve the metrics. Like Dr. Thompson said, we save lives. So we've come to the end of our podcast. We're really glad you could join us. We hope the information provided is insightful, valuable, and that you apply it. Again, Mayo Clinic's Key into Quality podcast aims to highlight some first steps in addressing important quality challenges in your organization. Our goal is to improve quality for patients and the populations that we all serve. If you enjoyed this podcast, we'd be grateful if you left us a review on Apple Podcasts, a rating on Spotify, or feedback wherever you listen. Share it with others so that the work can be spread. Until next time, goodbye.